So the agenda for today, we're going to just do a little bit of review of some of the diabetes labs, and then we'll talk a little bit about metformin and hyperkalemia. We talked about before type 2, sometimes when it gets pretty progressed, the cells, they need insulin too. But generally at the beginning of type 2 diabetes, your body is still producing insulin. So you don't need insulin, you need other medications. But sometimes when it gets really bad, you need that extra help because your pancreas doesn't stop producing insulin. Type 1 diabetes, your pancreas have been pretty destroyed by autoimmune destruction. So you need insulin for your cells to actually get the food that it needs taken up into the cells. And then type 2 diabetes, your body's making insulin, but the cells are like not really loving the insulin or binding the insulin. So it needs some extra help. What health complications can you have with type 2 diabetes? Because diabetes in general is affecting glucose in the blood. It really affects those blood vessels a lot. So some of the earlier things we see is your eyes getting affected because these are like the small vessels in the eyes, the small vessels that are in your kidneys, and the small vessels that attach to your nerves, especially the nerves in your feet and your hands. So those are the ones that can get damaged earliest on. And then you can also get some of like the bigger blood vessels affected, like the ones in your heart and in your brain. And then the peripheral vascular disease, so like the legs and the arms that can be affected from just having the higher amount of glucose in those vessels. It just damages some of the lining of those vessels, usually initially in the small vessels and then the bigger vessels. So smaller vessels are most at risk earlier, and then your bigger vessels, they're also getting a little damaged, but to get to progressed like heart disease and stroke, it takes a little bit longer, but all important for why we want to prevent these from happening with medications and diet and lifestyle. What's the best lab test to check for diabetes? So the gold standard is the hemoglobin A1C. It's measuring over the course of time because it's looking at how your blood cells are specifically binding to the sugar, to the glucose. And that sticks around in your blood for 3 months. So it gives us a better picture of what it looks like. Whereas your actual like straight up glucose level in your blood, the glucose that's floating around in your blood, that shows more recently the last few hours of what your body's sugar level looks like. So that changes more frequently. But the A1C is like a standard one that gives us a better picture of how it's been. But obviously we know that the glucose levels get higher right after you've eaten. So it kind of goes up and down. And that's a normal thing. If you have diabetes, it'll go up and down throughout the day based on what you're eating and when you're eating and all of that. The other ones are the glucose tolerance test and the finger stick glucose test and the continuous glucose monitoring. The glucose tolerance test is you'll take some glucose beforehand and then you test an hour after, 2 hours after, 3 hours after to see how your body is metabolizing that sugar. The finger stick glucose tests, these are the ones that are done at home. So you don't need like a laboratory like you do for the hemoglobin A1C to really see the level of glucose right away that's in your blood. Both this and the continuous glucose monitoring is looking at just the sugar that's floating around in your blood. The finger stick glucose test is seeing this one-time moment. The continuous glucose monitoring is a small machine that especially for type 1 diabetes to really get like a longer amount of time of seeing how the glucose is changing up and down throughout the day. Glucose tolerance test, the one where you drink some glucose and then see how it's monitoring, that's usually done with pregnancy because that gives us a better picture of how you're metabolizing within 1, 2, or 3 hours. Just remembering some of these numbers, pre-diabetes we know is from having an A1C of 5.7 to 6.4, and then diabetes is considered a diagnosis after the A1C is 6.5% or above, and normal is considered under 5.7. So when you're in this pre-diabetic range, not necessarily needing medication, but getting a little concerned that your cells are starting to develop some resistance to insulin because it's probably getting a little too much sugar that's affecting how the cells are taking up insulin. And then your fasting blood sugar in diabetes. So this is before you eat or have anything for the day. So as soon as you wake up, you haven't had anything since dinner the night before. If your glucose levels are over 126, that's showing, oh, wow, we still have a decent amount of sugar floating around in our system, even though we've been fasting. So that's considered diabetes. And then the pre-diabetes, there's still a decent amount of sugar floating in the system, even fasting is like 100 to 125. And then less than 100 is considered normal. And then glucose tolerance after an hour, a normal amount of glucose to be having in your system after taking this like specific amount of glucose that's given to you you at the doctor's office would be less than 140. And then pre-diabetes, we're seeing like 140 to 200. And then above 200 is seeing that your body still has a lot of sugar floating in its body and the cells haven't absorbed as much sugar as we'd want. In terms of how frequently that we check if we're diagnosed with diabetes, but pretty stable on the medications, this is typically 6 months. And if you've been controlled for like years, sometimes your doctor may space that out even more, but typically it's like every 6 months if you're not really needing medication adjustment and you're pretty well controlled at like 6.5% or like 7%, depending on what your goals are. Just to review, those goals of where your doctor wants you to be for your A1C really is dependent on some of your other health issues and your age. Having a really tight goal for diabetes can sometimes be harmful because it puts you at risk for hypoglycemia. So some doctors will be like, okay, 7 is good for your age. 7 is good because you have heart disease or kidney disease. Like we don't want to be risking you getting lower. And that's totally normal. And then if you're like newly diagnosed or you're starting a new medication or you're not well controlled, you should be checked every 3 months to see how those medications have affected you and whether we need to do a little changes. And then pre-diabetes, if you're really worried about it, you can always ask your doctor, but you probably don't need to get checked more than every 1 or 2 years. But if you're like, I did so many diet changes the past 6 months, like I really want to check, that's also reasonable to do it in 6 months. I would say 3 months is a little bit of a stretch if you're pre-diabetic to be checking as much because it may take a little bit longer with just diet and exercise to see your A1C go down. If you don't have diabetes, it really depends, but it's usually every 1 to 2 years. And this is also dependent. Like if it's a young person who's like 18 years old, doesn't have diabetes, I'm not going to be checking for diabetes every year. But if there's other risk factors like weight, like heart disease, like family history of diabetes, I may check a little bit more frequently. That's a little bit more flexible. Just a reminder about the fingerstick glucose test. This is what's done at home. It can be hard. People don't always have like the best circulation in their fingers, so it can be done in other ways too. But typically it's done at the finger, and that's something where you want to try to be hydrated, but it does sometimes help to squeeze out the blood a little bit after you've pricked yourself to get the blood into the reader. And then the continuous glucose monitor is usually with type 1 diabetes. So in terms of checking your glucose at home, the finger stick glucose test, you want to make sure you've washed your hands, you have your strip in the meter ready to go before you prick yourself, so you're not trying to maneuver it while you're pricking yourself. And then for the lancing device, it'll be usually at the tip of your finger. Sometimes people have a little bit more circulation depending on your anatomy, like on the sides a little bit. Then you use just a drop of blood onto the strip and it should like suck it up pretty easily. Most people I think don't have too much of an issue on how to use a glucose meter, but if that's something that's challenging for you, that's up to talk about with your doctor. And you can always bring in those glucose monitors and things into the office to have your doctor help maneuver it. And then the continuous glucose monitor, this one's a little more straightforward of like how it's done. It's to your abdomen specifically. This one is actually showing some of the newer ones that'll be inserted onto your abdomen, and it comes to like an app. And then oftentimes that data will also be sent to your doctor. On a side note, these are things that you only really need for type 1 diabetes, or if you're on insulin and have developed type 2 diabetes. I've also heard of people who don't have diabetes using these as like a new thing that's happening like with apps and stuff. And that's so silly. Do not do that.
You don't need that.
This is actually very risky. Like your body will have spikes. It should have spikes. When you're eating something, like it takes a second for your cells to absorb things. If you don't have diabetes, or even if you're not using insulin, sometimes it can be a little more alarming. You don't want to use recreational things that are being sold. Sometimes that's the issue with overdoing some of these health things. Then you're giving yourself a false scaredness about things that are not concerning. And sometimes it can give some extra frustration. I think it's fair if you are like, I've been making changes I want to see, but then I also caution people about that, because then if you've made these changes for like 3 months and you're like wanting to see, you might get discouraged by seeing that it's not working, but there are things going on in your body still healing, even if the lab result, those are just numbers. So there's always a bigger picture with it. Trust your process and your journey and stay encouraged about making all these changes, even the times that it gets discouraging. They're making some positive changes. I think there's some good things about just having some structure of how we think about our diet and exercise and getting into routine that can just be long-term really helpful. So don't always get so hung up on the numbers. And that goes across the board of if you have diabetes or not as well. We reviewed some of this of using fingertips. There is lancing devices if it's really painful for some reason, or you're really sensitive to some of the finger stick pricking. There's ones that can alleviate that a little bit. You generally want to find like the fleshiest area to use. A lot lot of these targets are really based on what's going on with your health and your age. Some people maybe 6.5% is the goal because as we know, it's 6.5% and above that's considered diabetes. But sometimes because we really want to avoid the risk of low blood sugar, a lot of the goals are often like 7% and can even be like 8% for some people that had really uncontrolled diabetes. And we want to get them to a place of like 8% is like the best bang for your buck kind of thing. It's least harmful and least risky with having that goal, even though that seems high still. For some people, that's considered actually like a really good goal. So that really depends on what conditions you have, your age, how long you've had diabetes, how many medications you've been trying. So that's really individualized. Just to review the blood sugar log, especially looking at if you are relatively well controlled, if your doctor has said that you just need to test your blood sugar like once a day, then you only need to do it once a day. But if they're like, oh, you're uncontrolled and we're not sure what's happening with your sugars, it's a good idea to just come in with this written out. I love when patients have all their blood sugars written out because then I could really see like when it's going down. And that helps us know when we can tell our patients to take the insulin because all of this timing is very important with insulin, especially like fasting insulin. Fasting is the most important. And then before dinner, if you're only testing 2, but then if we want like a bigger picture, also seeing right before breakfast, right before lunch, and then right before dinner. I would say fasting or right before dinner or even fasting and then right before bedtime, if you're doing 2 of them, is helpful. And just a review of other labs, you want to make sure you're checking your kidneys. If you see the doctor every 3 months or once a month, you might get this like general test of just looking at like all the metabolites. But this is a specific urine test as well as blood test to check your kidneys and how the ratio is protein excretion. And then you want to do a podiatry visit every year to make sure you're not having peripheral neuropathy. And then optometry visit every year, or ophthalmology is actually more ideal. Optometry is to see what glasses you need. If you do optometry, that's fine. Just make sure they also do a retinal exam. So they're actually seeing your retinas. Ophthalmology, especially if you have diabetes, is most ideal, but sometimes optometry is cheaper depending on your insurance. And then wanting to see your lipids. So seeing your cholesterol levels every year too. Just a good thing to remember what we need every year. We know your A1C, that goal may be every 3 months if you're changing medications or you're uncontrolled. It could be more like 6 months or a year if you're pre-diabetic. And then if you're on insulin and if you're uncontrolled, making sure you check your glucose at home and keeping a diary. I just want to review the medications a little bit. There are a lot of medications. A lot of these medications, it's mostly like endocrinologists that are real experts on it. So it takes a lot of learning and training to really know all the finite details of it. But it's just helpful to know overall some of the general things about the big medications that we use that are outside of insulin. So this is before you need insulin, some of the medications you can try. And then even with insulin, you still sometimes do an insulin combined with 1 or 2 of these medications. These are the big ones. And we'll talk about some of the major brand names with each of them. So metformin, the way that it works is that it decreases the amount of glucose that's produced by the liver. So even during fasting times where our liver will produce glucose when we're not eating because we always need glucose and our cells always need glucose. When you have diabetes, you already have enough glucose in your blood. So this is telling your liver to stop, that we don't need more glucose produced. So it keeps your blood sugar levels a little bit better controlled. It also makes your cells and your muscles to take up that insulin more and have that insulin help take up the glucose. So that also helps decrease your blood sugars a little bit. Very low risk of hypoglycemia, and it's very affordable. It can also cause a little bit of weight loss or weight neutral, like it won't cause an increase or decrease in weight. And then the biggest cons are diarrhea. It cannot be used with impaired kidney function. As far as like we know, it doesn't directly start a lot of the kidney dysfunction, but some people do have that risk originally that's not necessarily seen on labs prior to starting metformin, and then metformin can worsen it. The other 3 medications are like the big ones. GLP-1 agonists, so this is also Mounjaro as well. Trulicity, Victoza, Ozempic, Byetta, Adalimumab. This is in this family of GLP-1 agonists that have become a lot more of a first-line medication. Sometimes people will choose to start this even before starting metformin or instead of starting metformin because it can really help, especially with heart disease and stroke prevention for people who are at higher risk for it. And that's specifically just Trulicity, Victoza, and Ozempic. Mounjaro, I believe, does not help as much with heart disease, but they're all part of this family that prevents breaking down of these hormones that help reduce glucose levels. It's like a naturally occurring hormone, GLP-1, that happens in the body. This helps produce it and prevent the breakdown of those hormones. So it'll keep the glucose levels lower. This is not insulin, so it does not have a risk of hypoglycemia. Also can be really great for weight loss, as we know for Ozempic. The cons are that it's injected, it's relatively expensive, and then people sometimes experience gastrointestinal side effects like diarrhea, nausea, vomiting. And then the other big class is Jardiance, SGLT2 inhibitors. The other ones are Brenzavvy, Invokana. Jardiance is kind of the biggest one, but this works directly on the kidneys to prevent glucose from getting reabsorbed by the kidneys. So the pros of this is that it can reduce blood pressure, also has really good ways of preventing heart disease, similar to like Ozempic and Trulicity and Mounjaro, and then also helps with weight loss. They've also found that this can improve kidney outcomes. So often for people who have kidney disease, this is one of the first things we start with people. The cons for this is that because you're excreting more sugar, there is some increased risk of urinary tract infections and some fungal infections. And then bone fractures are reported as being a little bit more increased for people that use this medication. It's thiazolid, but it's Avandia and Actos. These are other ones that are like second or third line after Trulicity, Mounjaro, Jardiance, Metformin. But this is another one. The way that it works is that it helps insulin work better in muscle and fat tissues, and it reduces glucose production in the liver. So a little bit similar to how Metformin works, but it doesn't have quite as much of the diarrhea side effects, and it's safer in the kidneys than Metformin is. Another pro of this is low risk of hypoglycemia. The con is that if you have heart failure, it can increase risk for that. So it's something that shouldn't be used in heart failure, or if there's like a really strong history of heart failure in the family. It can also cause some swelling in the legs. So just to talk about the medications to start with, if you just have diabetes and there's no other comorbidities, like other medical issues like heart disease, hypertension, obesity, high cholesterol, if it's just diabetes and it's like between 6.5, 7.5, that's when you're pretty low risk. You probably just need metformin, or if you don't have any contraindications to metformin. And then all of this is diet and exercise and meeting with a nutritionist and being pretty diligent on changing some of those lifestyle things. And then if your hemoglobin A1C is over 7.5, that's a little bit higher. If this is like before you've tried any medication, then we may do metformin with another second or third agent. That's typically the GLP-1 or the SGLT2. So that's like the Trulicity and Mounjaro and Ozempic. If it's pretty bad or if there's other concerns, other health issues, then we may do a third agent. But typically, if it's over 7.5, doing two agents, something like metformin and something else is the best. And then if you're over 9, like just starting out with, you may need insulin, especially initially, to at least bring you down. If you're able to get down pretty quickly from 9, then we may be able to transition you to a different medication. If there's diabetes as well as chronic kidney disease, the SGLT2, that's the Jardiance, that'll be the best because it helps the best with the kidneys. And heart failure, because heart failure often actually works with the kidneys as well, we found that also Jardiance is the best first option if you have diabetes as well as heart failure. And then with other health issues along with diabetes like heart disease, obesity, hypertension, smoking, high cholesterol, we will start with either the Jardiance or the Trulicity. So these are things we start even before metformin, because metformin we use mostly to help specifically just with the A1C, with those targets and getting you lower. When you have diabetes and kidney issues or heart issues or other things going on, the goals are a little bit different. The goals are get your body to a healthier place overall, and not necessarily that we're strictly just looking at the glucose levels. We just want your overall body to be healthier. So we see that medications like Trulicity, Jardiance can be a little bit more helpful with that. And this is also GLP-1s, Mounjaro as well, and Ozempic. There's a handful of medications in each of these type of families. Adding another medication, so if you have heart disease and you start out with the Jardiance or Trulicity, if you start out with Trulicity, we may say after 3 months, if we're not really seeing a good adjustment in the A1C, then we may add in Jardiance as well. You really don't add two things in the same class because that's kind of just targeting the same thing. So we try to pick and choose from different classes depending on what you need, but trying to titrate up. The Avandia or Actos, you consider adding that as well along with those two medications if you're still not reaching the target after like 6 months or even longer. reassessing and modifying treatment is the biggest thing every 3 to 6 months. It's a tricky thing of what your goals are, and it's very catered to the individual, depending on what other health issues are going on in the body, of what we really care about happening. In terms of like what, when we're doing like the medications where we're really focusing on, we really want to get your glucose levels lower, and that's the biggest priority. It's like insulin, and then also like dulaglutide, semaglutide, tirzepatide, and then the GLP-1 combined with insulin. So those are like Trulicity. That's like really effective at lowering glucose. And then the intermediate ones, we didn't talk about DPP for eyes, but those are another ones that work pretty similar to the GLP-1s, like Ozempic and stuff, and those can help. So these are the biggest ones. And metformin is also something that can really help with the glucose lowering, and because it just has a really high safety and cost, it's often like used as first line in combination with other things when the goal is just glucose lowering. And weight loss is one of the big other goals because that really affects diabetes. The biggest first line things are like semaglutide, dulaglutide. All of these are types of the GLP-1, so like Mounjaro and all of those. This is all to say that there's certain medications. GLP-1s are the most effective for weight loss. SGLT2s are most effective for kidney disease that you start right away. Also, both of these are really high yield for heart disease. Some of this is newer evidence that we've seen. Historically, we've just been like metformin right away and start immediately metformin no matter what your other comorbidities are. And that's really changed because we've seen that metformin may be helpful if you have a lower A1C and if you don't have other comorbidities. And even if you have those comorbidities, it may help lower your A1C, but it's not really helping as much with decreasing your cardiac risk compared to these other medications that are a little bit better. Sometimes you don't see any symptoms. That's the most common. You don't see any symptoms, which is also why these are things that are often monitored and should be monitored. Like kidney, the microalbumin creatinine ratio, that's done once yearly, but with your diabetes medications, there's just the creatinine level that's usually tested every 3 months when you have medication changes for diabetes. So that's what shows us when there's kidney damage. Some of the symptoms related to kidney damage, you may see some urinary symptoms, but it's honestly not quite as common. You often will see like a lot more kidney failure of not producing enough urine or having difficulty urinating at really high levels of creatinine, so at really severe levels of kidney damage. So kidney disease is a pretty insidious process. It's like a slower thing to really see symptoms and evidence from it. You can sometimes see swelling and other things, but that's also a little non-specific of whether that's like from your kidneys versus not. This is also why you want to be checking your kidneys and then just general kidney health. I think some of the hyperkalemia stuff is actually pretty pertinent to this for kidney health in general. If you have kidney disease in your family, that's a big thing, or you're very concerned about kidney disease, or you've had hyperkalemia episodes, you want to avoid certain medications for hypertension. So like lisinopril, amlodipine, spironolactone, and then NSAIDs like ibuprofen can affect your kidneys. Potassium is pretty linked with kidney damage of some sort. So just avoiding like really high potassium foods.
And it's funny too, because the foods that you might otherwise associate with being pretty healthy. So it's a good thing to distinguish for people who are experiencing it.
But generally knowing hyperkalemia, it's not an automatic thing to be worried about in diabetes, but it can happen if your kidneys get a little damaged and also if you're taking some other medications. So just something to be aware about.